Alright, so we've talked about the anatomy and just the structures, and now we're going to talk more about the physiology of breathing and just kind of how it all works together. A lot of this should be a review. Once we actually get to the respiration part, that's where some of the newer stuff comes in. And so, just like I talked about just a minute ago, the pulmonary system and the cardiovascular system, they both work together. The role of the respiratory system mechanically is going to be to get the air and get the oxygen to the cardiovascular system, right? So the respiratory system is really the start of the assembly line. It does really the grunt work. It actually gets the oxygen there, the physical oxygen. It gets it there, and it sends it to the cardiovascular system. Once the cardiovascular system picks it up, then it goes from there. The respiratory system just brings what the cardiovascular system brings back to it and sends it out. So the CV system, it takes the oxygen to the cells, and it brings the CO2 back. So it's really the transport system for the oxygen. So ventilation is the mechanical process, right? The physical act of moving air into and out of the lungs. Oxygenation is going to be more of the chemical processes, right? Onloading of oxygen, offloading of CO2. And then respiration, you're not going to actually have respiration occur unless two things happen. Unless you have onloading of oxygen and offloading of CO2, right? That's respiration, is giving oxygen, taking out waste. Moving air into the lungs is inhalation. Moving it out is exhalation. So, inhalation is active. It's an active process. It being an active process means it's going to require what to occur? Just like active transport requires it to occur. Energy. It's going to cause work, right? To breathe in, it physically causes it to be an active process. There's a couple of new terms. We might have mentioned them briefly in advanced EMT, but a couple of laws that you're going to be introduced to. Boyle's Law. And Boyle's Law means that the pressure of a gas is inversely proportional to its volume. So what's the process called when we're actually moving gases across different barriers and moving them from areas of higher concentration to areas of lower concentration and vice versa? Diffusion. So the respiratory system, the process of moving gas, all works under diffusion. And so if you've ever had chemistry, I guess, would be where you talk about it. You may have heard some of these laws because Boyle's Law, Henry's Law, Dalton's Law, all those don't pertain specifically to the respiratory system, but they pertain to gases in general. So, Boyle's Law, the pressure of a gas is inversely proportional to its volume. The more volume of a gas, the more pressure it's going to exert. Seems kind of common sense, right? For this process of inhalation to occur, we're going to have the diaphragm and the intercostal muscles to contract and to bring in the air by the process of negative pressure, right? We've talked about the diaphragm. The lungs, they have no muscle tissue, so they have to depend on the other muscles to help them contract, okay? They depend on the movement of the chest and the supporting structures. So that's why if we have some type of traumatic injury that compromises the chest integrity, or if we have some kind of abdominal injury that compromises the diaphragm, that's why we can't breathe very well, because the lungs depend on these muscles to create this negative pressure. Just like a balloon depends on you blowing that balloon, blowing air into that balloon for it to expand. If it doesn't, it's just going to sit there. Okay? Maximum inhalation occurs when the diaphragm and the intercostal muscles are contracted and the lungs fill with air. So once they've contracted to the most point that they can contract, the lungs should be as full as they can get. You can't get any more air into the lungs without having the diaphragm or the intercostal muscles contract further. The thoracic cage is what actually helps create the negative suction with the diaphragm. So it takes the diaphragm pulling down and the intercostal muscles making the thoracic cage push out to create that negative suction. So naturally, if you just sit here and you're not breathing, your lungs and all that are just sitting in your resting state, do you have negative pressure or positive pressure or what inside your lungs? So it should be equalized, right? But it's still going to be a little bit negative, okay? Because you still have to have a little bit of that negative pressure to help keep the lungs expanded, okay? So if you took somebody that wasn't breathing right now and you shoved a needle in their chest and opened it up, it's still going to push air out because there's still a little bit of negative pressure. So what's one of the processes that makes inhalation stop? When you're breathing normally. Right, right. The answer's up here. So when you're breathing in, creating negative pressure, once that pressure is equalized to the atmospheric pressure, there's no more negative pressure, so there's no way to suck in any more air. It's going to stop. Then what pushes the air out? Positive pressure. By the lungs contracting down, they're forcing that air out. I think it's pretty, I think we've got this pretty good, don't y'all? Y'all understand really the process of inhalation? So, diffusion is going to really occur in inhalation, right? When we're breathing in, it's going to take that new oxygen in, right? So that's when diffusion is going to occur. Once we exhale, diffusion's already occurred, and the oxygen has went in, the CO2 has come out. So diffusion involves the oxygen transfer from air into the capillary. So when we breathe in, we're not breathing 100% oxygen, right? How much oxygen are we actually breathing in? Yeah, about 20.9, 21% oxygen. That is the partial pressure of atmospheric oxygen. That's at sea level, okay? The partial pressure is the amount of gas in air or dissolved in a liquid. So we can measure partial pressure, which is the amount of gas. We can measure the amount of gas, the partial pressure, the amount of gas in air, or that gas can be dissolved in a liquid, and we're still going to measure it by partial pressure. Why do you think I emphasize that? Why do you think I emphasize dissolved in a liquid? Because the blood is a liquid medium and it carries a gas, which is oxygen, or CO2, throughout the body. So when we get those arterial blood gases, we're measuring the partial pressure of O2 and of CO2 in the blood. We are measuring the amount of gas in the blood. When I was in paramedic school, I had a really hard time grasping some of these things that we're going to talk about now. And so one thing about teachers a lot of times is that we'll teach the way that we learn things and all that. And so that's why I put special emphasis on some of these things, because some of these are some of the harder concepts that I really didn't get a good grasp on until I got into the ICU dealing with blood gases and stuff. Because simply, you're never going to really draw blood gas out in the field unless you're working like with a critical care agency and they've got an ISTAT machine or something like that. So the partial pressure, which is the measurement of the amount of gas in air dissolved in a liquid, is governed by Henry's. Henry has this law. Henry states that the amount of gas in a solution varies directly with the partial pressure of a gas over the solution. So the higher the pressure, the more of that gas that will enter the liquid. Can somebody explain that to me?
You got 2 little bottles, and they fill it with pressure. The pressure builds, push it against, that's why we go to the parts.
Mm-hmm.
That's how we go.
Yeah, yeah. Yep.
It's just pressure traps all that
Right.
gas in the soda.
Right, that's right. So the amount of gas in a solution varies directly with the partial pressure of a gas over the solution. So the higher the pressure, the more of that gas that will enter the liquid. So use Kane's example. All right? Take a 2-liter bottle. When it's in its resting state, if you open it, the gas is in the atmosphere of the bottle. Okay? So the gas just seeps out when you open it, right? But if you shake it up, it causes a lot more pressure. And so that, what is it, carbon dioxide that they make to whatever it is that they make to carbonate stuff. So if you shake it up or whatever, it's going to increase the pressure of that gas. And so by increasing that pressure of that gas, it's actually going to force it into the cola. All right, by that process. So the higher the pressure, it's going to force that gas into the cola, which mixes it in. So that's why once that pressure is real high, it's going to push that liquid out because the gas has diffused into it.
And is this referring to the same concept of scuba diving, why you have to come up slow, slowly, so you don't get
Yeah.
aircraft in?
Yeah, because of the nitrogen getting into the cells and all that. Yeah, and if somebody, think about it like if somebody scuba dives and they come up too fast, the pressure has forced that nitrogen into the body, right? Into the bloodstream, into the vessels and all that. So what has to happen for them to not die? Right. So if they come out, they have to go to a hyperbaric chamber, which is going to force atmospheric pressure, higher grades of atmospheric pressure, to force that air out. Okay? All right? So how would Boyle's law and Henry's law kind of go hand in hand in the respiratory system? Somebody tell me what Boyle's law was.
The pressure of gas is proportional to its volume.
Okay. So the more of a gas you've got, the more pressure you're going to have, right? It's volume. You have a higher volume of gas, you've got more pressure. You've got the ability to create more pressure with that gas. And so what does Henry's law say? The amount of a gas in a solution varies directly with the partial pressure of a gas over the solution. So, take Boyle's law, and it says the more volume you have, really the greater the pressures. So the easier you can get it into a fluid. Okay? And take Henry's. The amount of a gas in a solution varies directly with the partial pressure of a gas over the solution. So the more of a gas the more of oxygen that you have, the more pressure it's going to be able to create to force it into the bloodstream. The less gas you have, the less oxygen you have, the less ability it has to create a partial pressure that's going to be able to force it into the bloodstream. Simply put, the lesser amounts of oxygen that are readily available to be breathed into the bloodstream, lesser amounts of oxygen that's going to be saturated to the hemoglobin in the blood. Greater amounts of oxygen that are readily available, greater amounts are going to be diffused into the blood. These are measured in mmHg. What is mmHg? Millimeters of mercury. Deoxygenated arterial blood from the heart has a partial pressure of oxygen that is lower than the partial pressure of oxygen in the alveoli. And so this kind of goes back to the laws there. Why? And it's really, don't make it any more confusing than what I've made it to you. It's really pretty simple. Why would the partial pressure of oxygen be lower in deoxygenated arterial blood than it would be in arterial oxygenated blood that's at the alveoli?
There's less stuff crammed into the blood.
Right. At the alveoli, the partial pressure of oxygen is higher because there's a greater volume of gas, right? There's a greater volume of oxygen at the alveoli. So the partial pressure in the blood is greater. But then what does that blood do with that oxygen? Yeah, it distributes it throughout the body. So when that deoxygenated blood when that blood becomes deoxygenated, it's not going to have the same amount of gas that's readily available, and so the partial pressures are going to be lower. Why do you think it's important for us to understand about the partial pressures of a gas in the blood? So that we know what they're really circulating, all right? Because is a SpO2 always the most reliable oxygenation tool? No. Obviously, their appearance is probably going to be one of the most reliable ways, but I've seen people that are sitting here that are normal color in no distress with a oxygen saturation of 89 or 90%. And I've seen people that have an oxygenation or an oxygen saturation that's 98% in apparent respiratory distress. And that's just because an SpO2 is only going to measure what any hemoglobin, how much oxygen any hemoglobin is saturated with oxygen. All right? But they may not have the same amount of oxygen in their bloodstream even though they're reading 100%. All right? Does that make sense? I told you guys, or the example that I use is, and these are just Nick's numbers. You have 5 hemoglobin molecules. Every one of those 5 hemoglobin molecules is 100% saturated with oxygen. What's your SpO2 going to read? All right. You got 10 hemoglobin molecules. Every one of them saturated with 100% oxygen. What is it going to read? 100%. Who's going to have a higher partial pressure of oxygen in their blood? The person with 5 molecules or the person with 10 molecules? The person with 10. All right? Who's going to perfuse better? The person with 5 molecules that's reading 100% or the person with 10 molecules that's reading 100%? 10. Does that make sense at all to you guys?
Hey, next question. The only place in the body where you don't have deoxygenated arterial blood is at the alveoli, right?
No. What other artery transfers deoxygenated blood? Yeah. So we can can get pulmonary pressures as well.
Have you ever watched something that shows health freaking nature for formulation? They do really good shit. They tell people like there was a dude learning how to control his nervous system to where he basically constricts all the blood away from the surface of his body and sat in an ice chamber for an hour.
Wow.
And his temperature, his core temperature never dropped below 90.
Wow.
Naked. I mean, when he wasn't. Had a dude riding a bike at about 30,000 feet. His oxygen sat was like 93.
Wow. All right. Here are some terms that you've heard before, so we're not going to spend a ton of time on this. Lung volumes. Alveolar volume is the volume of air that reaches the alveoli. Tidal volume is the amount of air moved in or out in one breath. Normal tidal volume is 5 to 7 milliliters per kilogram, which roughly equals about 500 to 750 milliliters per kilogram. And then infants is 6 to 8. So alveolar volume is going to be the volume of air that reaches the alveoli with each breath. The tidal volume is going to be the amount of air that's taken in or out with each breath. Dead space volume. Somebody breathes 500 milliliters of tidal volume. That's how much they've taken in. How much? What's the volume? 350. Somebody already knew that answer. About 350 milliliters of that air is actually going to be utilized. Where does this other stuff hang out? In the dead space. The dead space volume. And then the minute volume is the amount of air moved through the respiratory tract in 1 minute. Now, these minute volumes, this is going to include the anatomic dead space, meaning it's going to be measuring the total volume of air. I want to go back just a minute. On the partial pressures in Henry's Law, a couple things that I just want you to be sure that you highlight or jot down. So again, the partial pressure is the amount of gas in the air dissolved in the liquid. In our case, it's going to be the amount of it in the blood. The amount of a gas in a solution varies directly with the partial pressure of a gas over the solution. So in order for that gas to be diffused into the solution, it has to have pressure to push it in. As the presence of a gas over a liquid decreases, the amount of gas dissolved in the liquid will also decrease. So if that pressure outside of the blood does not remain constant, then the amount of oxygen in the blood is going to decrease as that amount of pressure starts fading away and isn't there to keep it pushed into the liquid. As more pressure is applied over the liquid, more gas can be dissolved in the liquid. Molecules of a gas can be dissolved in a liquid and remain in the liquid as long as the liquid is in a pressurized closed container. What is our pressurized closed container? The circulatory system. The partial pressure of oxygen in the air residing in the alveoli is about 104 millimeters of mercury. And then carbon dioxide enters the alveoli from the blood and causes a partial pressure of 40. Deoxygenated arterial blood from the heart has a partial pressure that is lower than the partial pressure of oxygen in the alveoli. That's what we just talked about. The body attempts to equalize the partial pressure. Alright? Just like with osmosis or regular diffusion, the body's trying to equalize. Oxygen diffuses across the alveolar capillary membrane in the blood. Carbon dioxide diffuses in the alveoli and is eliminated during exhalation. Oxygen and carbon dioxide both diffuse until the partial pressure is equal. And then, once arterial blood reaches the tissues, oxygen diffuses into the tissue and then into the cells, and carbon dioxide diffuses out of the cells and into the fluid in the blood. So y'all know this process. Y'all know this process. It's the process of respiration. It's the process of internal and external respiration. So instead of just leaving it at internal respiration is the onloading of oxygen and the offloading of CO2, or the offloading of oxygen, onloading of CO2 on the blood, instead of just leaving it there, we're talking a little bit more about how that gas is actually transported throughout the blood and how it's actually delivered to the cells. Not just saying, okay, we know that it comes on and goes off. This is how it actually happens, and it's by the pressures, okay? The inspiratory reserve volume is the amount of air inhaled in addition to the normal tidal volume. So the way that they measure this is they'll get you to take a deep breath, and then they'll try to get you to take more. And that's what your inspiratory reserve volume is. The functional reserve capacity is the amount of air forced from the lungs in one exhalation. This is forced. And then the expiratory reserve volume is once we've forced all this out, we're trying to get the rest of it out. That's all I can get out. And then the residual volume is the air that remains in the lungs after maximal exhalation. Your vital capacity is the amount of air that can be forcefully exhaled after a full inhalation. Then your total lung capacity is your vital capacity plus your residual volume. And that's usually about 6,000 milliliters in a healthy man. Why do you think they take all these measurements? Yeah, I mean, really, it's just we won't really do much of these measurements at all, but it's really for like a pulmonologist or someone to see really the state of health that their lungs are in. Exhalation is a passive process, meaning that it doesn't take a lot of work. The balloons have stretched, and now they're forcing the air back out. The process of exhalation goes and goes and goes until these receptors, these stretch receptors, signal the apneustic center that, hey, we've reached our max potential. We've stretched to the max. Now let's exhale. When somebody's breathing in and then exhalation starts, the feedback that tells the apneustic center, hey, we've stretched as far as we can, we need to start exhaling, is the Herring-Brewer reflex. The Herring-Brewer reflex. And then all the Herring-Brewer reflex really is a protective mechanism that terminates inhalation, which prevents the overexpansion of the lungs. Because if it's a weak lung, overexpansion could cause what? Yeah. A bleb and a pneumo. Do we always require the same amount of oxygen? No. The body has the compensatory mechanisms to determine what type, how much oxygen that we need. The respiratory system responds by altering the rate and depth of ventilation. So if we're exercising, we're going to breathe harder because we need more oxygen. If we're just resting, we may breathe lighter because the body's not requiring that much demand. this is really regulated by the pH. By the pH in the blood and in the CSF. Why would pH regulate our breathing? Why would the acidity or the alkalinity of our blood regulate our breathing or our CSF? Right. Because our blood is going to become acidic when what increases in it? CO2, or when what decreases in it? Not oxygen, bicarbonate. Alright? When oxygen decreases in the blood, CO2 is usually going to increase in the blood. Alright? This is going to be directly related to the amount of CO2 dissolved in the plasma portion of the blood. So that's what these receptors are going to be looking at, is the amount of CO2. This whole feedback mechanism is a pretty complex mechanism that we're not going to get super deep into. Pretty much what they do is that they send messages to the respiratory center. Where's the respiratory center? The medulla and the pons. The medulla and the pons. So rising CO2 levels is going to suspend breathing. Why would rising levels of O2? Why would rising levels of O2 suspend breathing?
Because the body's got enough oxygen.
Right. Because those receptors are saying, hey, we got plenty of oxygen. You can slow your breathing down. Why would rising levels of CO2 increase breathing? Yeah. Hey, we've got too much CO2 in the blood. We need to get that off and get more oxygen in. For most people, I've already talked about this. For most people, the drive to breathe is based on the pH changes in the blood and the CSF. And these are regulated by these chemoreceptors, okay? These feedback mechanisms. These chemoreceptors are what sends the signals to the medulla and the pons to slow or speed up breathing. They monitor the chemical composition of the body fluids. What chemicals are they monitoring? CO2 and oxygen, right? And they provide a feedback on the metabolic processes. What's the metabolic processes? What happens when your metabolism is activated? What is metabolism? Yeah, creating of energy. So it monitors the body's processes of creating energy. You're not the only one in here. There's 3 sets of chemoreceptors that affect respiratory function. You need to know this big time. You've got the carotid, the ones that are in the carotid bodies. Where are your carotids? Right here. You've got chemoreceptors that are in the aortic arch. Right here. And then you've got central chemoreceptors, which are going to be in the brain, in the medulla, in the pons. The carotid and aortic arch chemoreceptors measure the CO2 in the arterial blood. The central chemoreceptors are going to monitor pH in the cerebrospinal fluid. The chemoreceptors in the carotid bodies and the aortic arch, they send signals to the respiratory center by the glossopharyngeal nerve, which is the 9th cranial nerve, and the vagus nerve, which is the 10th cranial nerve. And then the central chemoreceptors when they monitor the pH in the CSF, they're looking for the acidity of the CSF, which in turn is going to be an indirect measure of the amount of carbon dioxide in the arterial blood. When it's measuring in the CSF, it's really looking at the carbonic acid. Because when CO2 hits the brain in the arteries, it crosses the blood-brain barrier and it combines with water. When CO2 combines with water, it forms carbonic acid. And that's what it's measuring in the CSF. The dorsal group and the ventral group chemoreceptors, y'all just go back and kind of read over this stuff. Initiates inspiration based on information from the chemoreceptors. And then the ventral group is responsible for motor control of the breathing muscles. The hypoxic drive. So most people breathe off of what stimulus? All right? Lowering, decreasing levels of oxygen and increasing levels of CO2. A person that has some type of chronic respiratory illness lives every day with lower levels of O2, right? So their chemoreceptors aren't going to pick up on the CO2 or the lower levels of O2. As a matter of fact, if their levels of O2 start going up, whereas if our levels of O2 were real low, our chemoreceptors would signal our brain to breathe fast and to send the oxygen levels up. With theirs, if their oxygen levels don't stay a little bit lower, if they start going up, it's going to tell the brain, hey, you've got way too much oxygen, you can just slow down and quit breathing right now. And that's what we mean by knocking out the hypoxic drive. So that's why you always hear don't put tons of oxygen on somebody with COPD. Because if we give them too much oxygen, the brain's going to get the signal and say, hey, you've got a lot of oxygen, you can stop breathing. And then they're going to quit breathing. With a hypoxic drive, as far as pre-hospital, we're not going to withhold oxygen, right? Patients that have COPD, they're always going to have higher levels of CO2 in their blood. And so this is going to alter that primary respiratory drive, which is based on increased arterial CO2 levels and the pH of the CSF. The theory behind this is that respiratory centers in the brain gradually accommodate elevated carbon dioxide levels. So the body's just really compensating and saying, hey, I'm used to having this much CO2, so you start taking this CO2 out, then I'm going to start having issues.
So those receptors in CSF, where it's at, that tells the rest of the body the amount of carbon dioxide it has in it.
Well, it's those central monitorings, the ones that I just talked about just a minute ago, that's in the medulla and the pons, they're the ones that monitor the CSF. And so they will measure the carbonic acid in the CSF, which is a direct reflection of the CO2 that's in the arterial blood.
And it has a huge impact on hypoxic breathing.
Yep. Other factors that mess with ventilation, any type of hypermetabolic state, such as fever, medications, y'all know all these. Oxygenation. This is where we're going to load the hemoglobin, oxygen onto the hemoglobin. In order for oxygenation to occur, we've got to have an adequate amount of atmospheric pressure of oxygen, okay? A person that's in a oxygen-deprived atmosphere cannot be oxygenated. That's pretty simple, right? I mean, it's pretty self-explanatory. Somebody explain this. It's required for ventilation, but ventilation does not guarantee oxygenation.
If you're in a mine or something, where you're breathing, you can still be breathing, but the pressure isn't high enough.
Right,
Or
right.
push it into the blood.
Yeah, I can breathe in oxygen-deprived atmospheric air and ventilate, right? Because ventilation is just a mechanical process, right? So I can actually physically breathe in that air, but oxygenation is not going to occur if I don't have the right amount of oxygen in the air. Confined spaces, like she said, is a good example of when that happens. Also, carbon monoxide. Because carbon monoxide has a higher affinity for hemoglobin, so I may breathe in this carbon monoxide and actually ventilate, but I want oxygenate because the carbon monoxide is going to attach to the hemoglobin. This is a term that you may not have heard before, the FiO2, or the fraction of inspired oxygen. This is the amount of oxygen in the inhaled air. It increases with supplemental oxygen and commonly documented as a decimal number. So, if I give somebody 15 liters, if I put a non-rebreather mask on somebody at 15 liters, what is the FiO2 that I'm giving them? 100%, give or take. Alright? So the FiO2 is just the amount of oxygen that they're going to be breathing in. So, if atmospheric pressure, in atmospheric pressure, oxygen is 21%, what is the, and we're breathing atmospheric oxygen, what is the fraction of oxygen that we're breathing in? We're looking at percents. We're looking at percents. 21%. Okay? Your FiO2 is just the percentage of oxygen that's in the available air. Alright? And this is altered with supplemental oxygen. If we give somebody 2 liters of nasal cannula, we're giving them enough to increase the FiO2 from 21%, which is normally what we're breathing, to about 24%. Okay? Does that make sense to you guys? It does? Okay. Do what? I don't know. And that may be true. But whenever I deal with FiO2 in the hospital, I deal with it all the time with ventilators because we have to give them a fraction of oxygen. It's always in percentages. 21% is the FiO2 of atmospheric air. 100% is the FiO2 of a non-rebreather mask because we're giving them nothing mixed with that oxygen but just straight oxygen. Alright. This next part here, the oxyhemoglobin dissociation curve. This is something that we're going to talk about today. You may see it on your test. You may see it on registry. It may not be something that really is monumental in your paramedic career. All right? But kind of understanding the process of what happens is. And what we're looking at in the oxyhemoglobin dissociation curve is going to be the amount of oxygen that is bound to hemoglobin. And there's several factors that will either inhibit or potentiate the binding of oxygen to hemoglobin. There's a couple of things that we look at, and that's the H and H, the hemoglobin and hematocrit. Anybody ever heard of the H and H before? So what we're looking at with the hemoglobin and hematocrit, the hemoglobin, we're looking at the protein, which is hemoglobin. We're looking at the amount that's in red blood cells. And then when we're looking at the hematocrit, we're looking at the percentage of red blood cells in whole blood. What's whole blood? That's everything that makes the liquid complex blood, right? The liquid substance of blood. And we know that blood isn't just red blood cells, right? It's white blood cells, it's plasmas, platelets, and all that. So we're looking at the total amount of red blood cells in whole blood with hematocrit levels. Hematocrit levels, hemoglobin levels are going to be, hemoglobin is going to be in the hematocrit, all right? So they would actually have to break the hematocrit down to get the hemoglobin levels, right? Because the hemoglobin is the protein that's in the red blood cells that carries oxygen. Why do you think in the hospital we may draw an H and H on somebody? Okay. So yeah, we'll look at, that'll be a good indication of perfusion status. If their hemoglobin levels are lower, then we know that they may not be perfusing the way that they need to. Alright, we could look at some of those things like anemia, iron deficiency, things like that. The hematocrit level is an important number for us to draw when we do look at anemia. Whether it's an acute anemia or a chronic anemia. If somebody is bleeding internally, their hematocrit levels will drop. Or if somebody is free bleeding, their hematocrit levels will drop because their body is ridding itself of red blood cells. Okay? Normal values of hemoglobin are what you see there. And those are numbers that we look at a pretty good bit in the hospital, not so much when you're on the ambulance. So this little dissociation curve, or dissociation curve, basically what it shows is that the SpO2, the partial pressure of atmospheric oxygen, and the partial pressure of arterial oxygen is proportional to the amount of oxygen dissolved in the plasma. So, basically, the saturation of oxygen to a hemoglobin cell is going to depend on the amount of pressure and the amount of available oxygen that's available. So if we have a pressure of 100 millimeters of mercury, we have a partial pressure of 100 millimeters of mercury that's applying pressure to the arterial blood. The If we've got more oxygen readily available, we've got more pressure to push that oxygen in. What's going to happen? It's going to push the oxygen into the arterial blood. What's that oxygen going to bind to? The hemoglobin. So if we have a higher pressure of oxygen available to the arterial blood, we're going to have a greater oxygen percentage.
How would you measure the amount of blood? You just use the word, I'm looking at it.
The partial pressure?
Yeah. How would you measure it? Like, I mean, you know, you see the graph, maybe that's just an explanation. But
You wouldn't measure it in the field. It's by the...
that's just the time that's done.
Yes. Now they can measure it through blood gases and stuff.
Yeah.
By seeing what the available amount of blood is in the arterial system, they'll know what the pressure was. All right?
Okay.
If you notice here that there is kind of a plateau right there. Basically what that means is that after it gets to about 105 millimeters of mercury, it can't really force any more oxygen onto that hemoglobin because that hemoglobin is completely saturated. And so the higher the SpO2 is, the more readily available it is to be distributed to the blood or to the cells. All right? Y'all follow me at all? What do you think are some things that contribute to lower partial pressures? Some of the things that would contribute to lower partial pressures. We just talked about it just a minute ago. Higher altitudes, confined spaces, just oxygen deprived areas. Now if you're in a higher, or if you're in an area that has higher amounts of oxygen, then you're going to have more oxygen that's readily available. Okay? Now, trying to make it a little bit less confusing. As the pressure of O2 increases, the hemoglobin becomes more saturated, just like we said. So this is pressure. As the pressure increases, the atmospheric pressure increases, it just means that it's going to force more oxygen into the blood, which makes it more readily available. Okay? Until it gets to that point. Pressure above 105 millimeters of mercury completely saturates the hemoglobin. Now this curve right here can be shifted to the left or shifted to the right. Alright? Meaning that it may take more pressure if it shifts to the right. It may take more pressure to get the oxygen levels up, or if it shifts to the left, it may take less pressure to get the oxygen levels up. All right? Acidosis and increased carbon dioxide, this makes the curve shift to the right. So if the blood is acidic, it's going to take more oxygen to get the oxygen levels up. It means that hemoglobin gives up oxygen faster, it doesn't hold on to it as long, and so it won't be as readily available to be transmitted to the cells. Then alkalosis and decreased carbon dioxide, this makes the curve shift to the left, and this means that the hemoglobin is going to hold on to more oxygen. The problem with that is that if somebody's alkalytic, then the hemoglobin is not going to transfer the oxygen. It's going to be stingy with oxygen. It's going to say, no, this is my oxygen. I'm not going to give it to the cell. All right? Again, just like some of this other stuff, this is stuff that you need to kind of have a grasp on. All right? But I don't want y'all to spend your first week of medic school completely freaking out over these new concepts and stuff, okay? I promise if you'll go do the interactive lecture, it explains stuff in pretty good detail as well. I've went through the cardiology and the respiratory, and they're pretty good. Metabolism is a process of cells taking energy from nutrients and creating energy. We know what respiration is, and we know that it involves all this stuff that we've talked about. Seems like we've talked about it a good bit, doesn't it? All right. I think we're going to call it